Thank you for joining us for our conversations, cases, and updates in myelodysplastic syndromes, practice-changing experts' insight into lower and higher risk MDS. During this segment, we will be discussing updates in the therapeutic management of patients with lower risk MDS. My name is Dr. DeAngelo, professor of medicine at Harvard Medical School. I'm joined here by my esteemed colleagues, Drs. Rami Komrokji and Dr. Mikkael Sekeres. So let's discuss the lower risk MDS, and we've had a discussion in terms of risk stratification, and we can talk about the higher risk later. But patients with higher risk disease, the risk there is risk of leukemic transformation and/or death, whereas patients with lower risk myelodysplastic syndrome suffer from different problems, transfusion requirements, sometimes mild, but very often very significant. And with lots of red blood cell transfusions comes lots of iron. And the question, of course, is that an issue? Should we be watching it? There are some patients with isolated anemia, some patients with two lines down, if you will, that are anemic and neutropenic or anemic and thrombocytopenic. And then, of course, there are those patients just with either neutropenia or thrombocytopenia. They're all very, very different. And how do we classify those and what leads to therapy? Focusing on at least trying to establish some ground for discussion, I'd like to start by focusing on patients with low-risk disease who are anemic. And what I mean by anemic is requiring some degree of red blood cell transfusion dependency. And so, the common approach or approaches that are available, first is erythropoietin-stimulating agents. There's a number of them, short-acting erythropoietin, longer-acting darbepoietin. And we typically will establish or measure an erythropoietin level. The lower the level, the more likely a patient is to respond to an erythropoietin-stimulating agent. That's not absolute, of course. Most patients, or the hallmark of myelodysplasia, is ineffective hematopoiesis. So the erythropoietin level is always elevated, but if it's very elevated, sometimes more is not more and doesn't help. There's that subset of patients with the deletion of 5q, the del5q MDS, that may respond very nicely to lenalidomide or other IMiDs, and that is an option. Patients with ring sideroblasts, mostly with SF3B1, but not always. Other splicing mutations, and sometimes without a splicing mutation, can lead to an increase in ring sideroblasts. And luspatercept, based on the randomized study, the Medalist study, was approved. And so I'd like to ask my colleagues, in terms of, maybe we can start with Mikkael, in terms of your approach to a patient with red blood cell transfusion anemia. Let's just take it. So a patient with deletion 5q, what is your approach, and how do you, what is it that you talk to with your patient?
A great question, Dan, and I think you summarized it really nicely. There's a spectrum of MDS patients and a spectrum of degrees of anemia. So my first step is to try to figure out when is it that anemia and then ultimately transfusion dependent is truly affecting a patient's quality of life. Because the dirty little truth about our therapies for lower risk MDS is that none of those therapies has been shown in a prospective randomized trial to improve a patient's overall survival. So ultimately, we're talking about trying to make some inroads into a patient's quality of life. Now, my rough back of the envelope estimate is that once a patient starts to require red blood cell transfusions more than once a month, we're getting into territory where an intervention is probably worthwhile. And this is how I do my calculus for this, and it's very simplistic. I try to think about my patient's life and what it takes for them to come here and get a transfusion, right? So they wake up in the morning, they've got a doctor's appointment, they walk to their car, they drive their car in Miami traffic, they drive their car in Miami traffic, they drive their car in Miami traffic, just like they do in Boston or Tampa traffic. They get here, they valet park it, or they walk from the garage, they check in, they go into the labs, they have their labs drawn, then they have to wait to see the doctor, they see the doctor, then they have to wait to go to the infusion center, they sit in the infusion chair, and then they get their blood for 2 hours and then go home, okay? So That was very boring, my detailing all of that. But think about it from a patient's perspective. That's a long day. So then, if we're going to, but if it's once a month, okay, they can deal with it once a month. If it's once every 2 weeks, boy, that's really starting to impact their quality of life. 1 day out of 14, they're doing that. So then we offer them therapies. Well, if you're going for a blood transfusion once a month or once every 2 months, but then we're asking you to come in for an injection every week, week in and week out, it's probably not worth it to get that injection, right? Even if it's just erythropoietin. So that's why I roughly think that once that transfusion becomes more frequent than once every month, that's the time that we intervene. I do start with erythropoiesis stimulating agents. I try to use darbepoetin because I think it's equiefficacious with recombinant humanized erythropoietin, and a patient can potentially get it every 3 weeks instead of every week. I do tend to use the Nordic approach to judging when someone's more likely to respond to an ESA. In other words, that patient has a relatively low serum erythropoietin level for somebody with MDS, let's say a serum EPO level of less than 200 or less than 100, and they don't have tremendous transfusion needs, they're more likely to respond to an ESA. Once I get into the area of things like lenalidomide for deletion 5q, remember the trial that got lenalidomide approved included 74% of patients who had previously been exposed to an ESA. So I think it's perfectly reasonable to try an ESA even in somebody who has a deletion 5q abnormality. And then when that drug fails our patients, because eventually they all fail our patients, that's when I pivot to using something like lenalidomide.
I think that latter statement is actually important because I have several examples where patients refer to me without a trial of an ESA and a relatively low EPO level. And I have patients in my own clinic who meet that classification. And as you mentioned, low transfusion requirements at presentation with a low EPO level, who have responded very nicely on ESA therapy for years without requiring escalation to lenalidomide. However, lenalidomide does offer the advantage of a tri-lineage improvement, and this issue of cytogenetic remission, although we don't know whether it improves survival as well. Rami, your approach to some of these patients, and if you wouldn't mind trying to focus on when you would initiate luspatercept in your patients.
Absolutely. So I think just to set the stage a little bit, because we've been trying really to look at the natural, progression or patterns of disease and lower risk. Mikkael and I presented data from the MDS Connect registry, looking at what happens to patients with lower risk. And we looked at 2,000 patients from Moffitt here. So it turns out that a majority of the patients in the lower risk, 70, 80%, will stay in the lower risk. There is 1/3 that's going to progress, and there are different patterns. They could go directly to AML, to higher risk MDS, then AML, or just to higher risk MDS. And we actually are interested to look into molecular profile, clinical phenotype of those patients that progress, because I think that 20, 30% that progress, we may think in the future differently of them. But the majority are gonna stay as lower risk. But when we look at those patients, it's actually 20, 25% of those patients may die within 2 years. It's very hard to assess exactly the cause of mortality in lower risk MDS because those patients' average ages are in their 70s, they have comorbidities. But, and in half of those, they are attributed to cytopenias, which I think are related or in an interplay between the comorbidities and cytopenia. Somebody have coronary artery disease, become severely anemic, that may impact it. So I think we have to start thinking differently. In the Connect registry that Mikkael and I presented, that there are some patients with moderate and severe anemia, a substantial number of them not receiving any treatment. So that's one point. But I agree in general, obviously, we wait till the patients have cytopenia that affects their quality of life or they're symptomatic. Most commonly, we treat anemia. And I think the approach mentioned is reasonable. I think luspatercept comes really in patients with, MDS ring sideroblasts at this point. There was, as you alluded, the medalist study that looked at luspatercept in transfusion-dependent lower risk with ring sideroblasts. And it led to a meaningful response or transfusion independency. In the original presentation, around 40% of the patients became transfusion independent. It's an injection given every 3 weeks, relatively well tolerated. One of the most predictors of response, important predictors of response, is really the magnitude of transfusion burden. So if you have a patient that's requiring a lot of blood transfusions on monthly basis, they probably are unlikely to respond. And they most often require a dose escalation, going to the highest dose that, in the higher transfusion burden. Outside the RS or SF3B1, it's still investigational. There was a press release on a study called the COMMAND study that randomized patients between ESA and luspatercept as an upfront strategy. So we have still to see that it was positive and met the primary endpoint. We have to see the data and see, are we going to move luspatercept earlier on in the treatment? Now, in the deletion 5q, I agree. I think there is recently some intriguing data from the Spanish group called the Rev Centra trial, where they actually took patients before coming transfusion dependent, and they randomized them to get a lower dose of lenalidomide. So those anemic but not transfusion dependent. They randomized them to take 5 milligram of lenalidomide, which is half of the dose, versus a placebo control arm, and only for 2 years, so not continuous therapy. And they looked at a different endpoint, which is transfusion-free survival or time to transfusion dependency. And in the treated arm, it was 6 to 7 years versus probably a year or so in the placebo arm. High cytogenetic responses. And in this past ASH, they presented some data that the molecular profile or the variant allele frequency of many of the mutations, even the P53, remained stable even with the earlier treatment. So it's a small study, it's intriguing, but makes us just to try to start thinking, if we have active therapies like lenalidomide, should we think of them earlier a little bit? We have to probably have a little bit more data. I'm still reluctant to do it on many patients. I mention it sometimes to patients, but I'm not starting it. The last point I want to bring up is the use of hypomethylating agents in lower risk, which is a phenomenon unique to the USA, because outside USA and Europe and Canada, they are not approved. And unfortunately, I still see a lot of sometimes inappropriate or early use of the hypomethylating agents. So I see patients sometimes MDS ring sideroblast, not even ESA trial, started on decitabine or azacitidine. I think those agents should be held as a last resort in patients with just pure anemia. If they've gone through ESA, other things, I feel very comfortable offering patients a clinical trial before HMA if they are anemic, or if patients have concomitant cytopenias that dictate that you cannot use it. Like if somebody have low platelets, less than 50, you probably cannot use lenalidomide. You're not going to get the tri-lineage responses with luspatercept in most of the cases. So there is a lot of liberal use of hypomethylating agents, and I think we have to be cautious about it. But we also are starting to have oral hypomethylating agents, which will make it appealing for the patients.
Yeah. I mean, I think that's a very good point that, delaying the use of DNA methyltransferase inhibitors, or as you refer to as hypomethylating agents, for patients with really pancytopenia or patients who have failed therapy. Other things to bring up that are often not done as often as maybe could be done is immune suppressive therapy for patients with hypoplastic MDS. It probably deserves a mention. But the role of TPO mimetic agents for patients specifically with a severe thrombocytopenia. Maybe Mikkael, you can comment briefly on your use of those agents.
Sure, I'm happy to. And I want to follow up on one point that Rami made, because this is a complicated topic. I also am hesitant to use lenalidomide earlier than I absolutely have to. During the oral presentation of those data from Europe, the presenter did concede that there were instances of TP53 arising in patients who had been treated with the lenalidomide early. I really do think we have a finite period of time to use lenalidomide in these patients, and I'm a big fan of it for deletion 5q, but only after patients become transfusion dependent. Regarding the TPO mimetics, there are two of them, L-trombopag and ramiplastim, that are commonly used in the treatment of MDS. I think the better studied of the two was ramiplastim. It was a large phase 2 randomized study in which patients received ramiplastim or placebo. Unfortunately, that study was stopped early because of a higher rate of evolution to AML in patients who received the ramiplastim. It was about 2.5-fold higher. Now, when you really dig into the data, you realize that the patients who transformed were much more likely to have started the study with excess blasts. So those patients who had refractory anemia with excess blasts up to about 10% were more likely to then blast off, because TPO mimetics do stimulate the growth of blasts. So while I do use it in my patients who are thrombocytopenic with lower risk MDS, I never give it to anyone who has excess blasts.
I think that's a very important point, and one that I don't think can be understated. But just briefly moving on to some of the other agents that are in development or that are being used, the supportive care issue, the Talisto study did address some of the key issues of iron chelation, maybe beyond the scope. I typically don't use iron chelation, at least in my clinic, unless patients are very heavily transfusion dependent and have a really long, what I expect to be a long natural history of life, and maybe developing some extra organ damage. But I think it's much talked about, at least in my clinic, and not as used. Some of the agents in development that are maybe on the horizon, based on Bill Kalin, Semenza, and Dr. Ratcliffe's Nobel Prize, is the HIF-1 alpha degrader Roxadustat is still in clinical development. And then imetelstat, which is a telomerase inhibitor, although maybe working through a different mechanism, seems to have a really robust, based on some data that our dear friend and colleague Dr. Steensma published a couple of years ago in lower risk MDS, seeing some transfusion independency. So we wait for the final report of some of that data. But to end on a couple cases that are maybe can be illustrative. Patients do require marrow examination. So a case of an 84-year-old woman that I saw with gradually progressive fatigue, becoming transfusion dependent, as Dr. Sekeres had mentioned, to the point of monthly transfusions. Marrow, shows no increase in blast, normal karyotype, SF3B1 and TET2 mutation only. And she really had isolated anemia. And this is a perfect patient to really think about luspatercept. Not only was the SF3B1 present, but on iron stain, which is very important on the aspirate, she had about 15 to 20% ring sideroblasts. And another illustrative case is a patient I saw a couple of weeks ago, an 87-year-old retired physician with chronic myelomonocytic leukemia, who had normal counts, but the platelet count started to gradually fall. And when I saw him, he had a normal white count of 6 with 20% monos, a hematocrit that was within the normal range, but his platelet count had dipped down to 15, and he was suffering from some episodes of epistasis and bruising. Marrow showed no increase in blasts, 1% rings, and a normal male karyotype, and mutation, nothing, avert, ASXL1, SRSF2, CBL, not surprising, and IDH. And he responded very nicely to single agent romoplastim. And I was able to actually reduce the dose and keep his platelet count in the 80 to 100 range without any intervention. And an 87-year-old, I conclude that as a victory. But just to summarize, lower risk MDS, the treatment is to treat symptoms, and the symptoms here are often cytopenias. We focus mostly on anemia. There's a lot of different strategies that are genetically based, either luspatercept for rings and SF3B1 or lenalidomide for deletion 5q. What is the ultimate timing of those is a little bit less clear, but don't forget, low dose DNA methyltransferase inhibitors for patients with pancytopenia, maybe immune suppression for patients with hypoplastic MDS, and there's a lot of emerging agents out there. And so in conclusion, I'd like to thank you for, again, joining us for this segment and updates and therapeutic management of lower risk MDS. Please be sure to click on the landing page for this activity to claim your AMA credit, assess supplemental slides, as well as other topic segments and case scenarios. Thank you very much.